Right, so I'm going to do this. Okay. All right. Okay, so the topic that I am presenting is called Opening Doors and Creating Opportunities. Okay. My disclosures is that one, I am in no means an expert in this field or have formal training in this area. I don't work for HR, no HR experience about career opportunities or promotions. What I'm sharing with you really is based on my personal experience of being a PA for over 25 years. After 25 years, I stopped counting, but also based on my experiences of the leadership roles that I have previously held as a manager in a lead APP, and currently I hold the role of an APP program manager. All right, so the topic I want to go over is about seeking opportunities and looking at the different roles and hats that an APP can wear. Okay, so this seems like a silly question, but we really have to ask why do we seek opportunities? Because it speaks towards what your personal motivation is, and what is it that motivates you to go the extra mile, hence the extra work hours. So one of, I'm going through a list of what I think a lot of us may agree on as why we seek opportunities. So first is career growth. As many of you know, there are not a lot of opportunities for APPs to advance in their careers, and people define career growth differently. This can be growth in terms of an actual promotion or a position change to a leadership role, or it could be personal goal of gaining new skills and adding something to your resume. Second is fulfill a clinical ladder requirement, if that is an option for you at your institution. Problem solving, you find a problem that moves you to take action, and that's what motivates you. And looking at checking a challenge and learning something new. And the other reason is sometimes an opportunity presents itself. You're not really looking for something, but there's some opportunity that's staring at you in the face and you seize that opportunity. And a good example is being invited to be part of a committee of some sort within your work area. So think of every opportunity that you come across as a door, because you don't know what's behind a door, that door, or where it may lead. And you may surprise yourself. There are things that you will learn that you're good at or you enjoy that you didn't think about. For example, there's one committee that I joined, and within that committee, they wanted somebody to work on the website to update the information. I would have never thought that I would take a class and learn how to update a website just for a particular committee. So just really kind of think outside of the box. On the flip side, I have been involved in projects like research projects, and I realized I absolutely hated doing research. I don't mind pulling up data and organizing data, but I hated writing papers. So you just kind of don't know what's out there until you actually give it a try to see if you might like it or not. So some of these examples of what's behind each door or what may open each door, or like I mentioned, committees at your institution, quality improvement projects, starting programs. I think some of this might resonate with some of you, like a pancreas cyst program or prevention program, survivorship programs, mentorship programs. And so what do you do if the opportunity does not come knocking? Then are you able to create your own opportunity? So this is actually kind of the message or the basis of my talk today, is that there are many situations, I think, for me, this was definitely the case where you're wanting career growth, you're wanting something new, working as an APP for over 20 years doing the exact same thing. Sometimes you need to create those opportunities to make things happen. So one of the ways is definitely networking, and that's even being here today, connecting with people, building relationships. We're networking on a daily basis, and sometimes you don't even think about that when you're going to meetings and meeting the people who you are working with. During, networking to solve problems and exchanging information and ideas. So, okay, so one area that I'm going to talk about is the role that I'm actually in. And for me to go through this, it's not to toot my own horn or to say, hey, look what I'm doing. But this position as an APP program manager has probably been the best position I've held. And I think it's very rare. And when I describe to you what I do, I think many of you might realize, oh, I kind of do the same thing, but I don't have that title. And it allows you to step outside of the zone of thinking as a leader, an APP leader, we have to be a lead or a supervisor or manager, when that's not the case. You can manage a project and not manage people. So I'm going to give you an example of what I do in case it helps anybody. So this particular position was created for me back in 2018. It was a position that in a way I was already doing. I was managing our pancreas program and managing my clinical practice. And then eventually they formalized the position. So what it is 50% clinical and then 50% program management. And that's on paper, but in reality, that's not the case. I'm probably more like 75 or 80% clinical. My clinical duties are surgical oncology outpatient clinic, and my program management duties is running the multidisciplinary pancreas cancer program and the pancreas prevention program or pancreas cyst program. So what I do within those programs pretty much range from problem solving, putting out fires, whatever it takes to maintain the program. And then if I'm lucky, I can focus on growing the program and outreach and research and so on and so forth. But it really ranges within all of those things that I've listed there. So when you're looking at building a program, how do you get started? First of all, you have to identify the need. So in my situation, we needed a more formalized pancreas program on the cancer side and the prevention cyst side. We knew that we needed that. But you can kind of think about what are the different programs. Could be fellowship programs, residency programs that are educational, QI projects and areas to improve different processes. The other thing you need to think about is what are the resources that you need in order to build a program? Definitely time. Do you need administrative support? Do you need any financial support? Definitely need support from the people you work with. And what you're trying to accomplish, has this ever been tried? Has it been tried and it failed? For what are the reasons, so that you're not going through and trying something that hasn't worked before, or looking at why it didn't work and correcting that. And looking ahead, where do you picture this leading? Is building a program just to give you some variety in your work? Is it, to lead to a formal position such as a promotion? Is it to improve patient care? And then lastly, is it sustainable? Is this a project that lasts a month, 6 months, a year, or is it something that you can actually sustain and say, hey, we need this program and it needs to stay around for patient care, or whatever reasons you're doing it for. So those are the things to look at if you're thinking, hey, this might be a good opportunity for me, or there's something in my group that I can build with regards to a program. So what are the big struggles that I face? Is definitely time. That's number one, because I don't think I have enough time allocated to the program the way that the position is set up. And bear in mind that I was the first one in the program, and I just checked with my boss, and currently I'm the only one in the program at UT Southwestern. So I don't really have somebody else to talk to with regards to how their clinic load is. The other struggles is, no administrative support, that the role of a program manager is not clearly defined. Somebody's got some music for me. So the role is not clearly defined, and because it's not clearly defined, the list of duties can be extensive and endless, and you can just spin your wheels just working nonstop. And then the second the last thing is, what is the metric for how successful you are in the program? And I have to think about this twice a year when I'm doing my evaluations. What have I done for the program? How is it measured? It's not RVUs like your clinical time is. Is it measured by return on investment? Are we increasing the volume of patients? What is the, how are you measuring success in your role as building the program? So this image here is different from the previous slide where I showed different people opening different doors. I like this particular image because it shows that one door can lead to another door, can lead to another door, can lead to another door. So it's kind of how you have to think about these opportunities, is that you might not find anything behind the first door, but it can open to the next door and the door after that, where you find something that you really like. So the general barriers that I think keeps people from looking for these opportunities as an APP is the fear of taking a risk, of stepping out of your comfort zone, not having the allotted time because you're 100% clinical and people expect you to show up for clinic or inpatient or do what you're doing. When do you find time to do these projects or get involved in program building? So it essentially starts off as time outside of work. Lack of support within the department could be a barrier. So depending on what that project is or what that program is, you can get a lot of support or no support at all. And the gains are not guaranteed. It's a leap of faith of, if I do this and my group sees what I'm doing, hopefully that translates into a promotion or a formal position or a raise, but it's not guaranteed. So you are investing all of this time not knowing what there is to gain from it. So some final thoughts. Don't be afraid to try something new. If opportunity doesn't knock on your door, then create your own opportunity. How you present your idea and yourself is just as important as the idea itself. Think outside the box and be willing to work outside the box. So if you get an opportunity that you're not sure you'll be good at, just give it a try. And you never know. Recognize that barriers exist, but don't treat them like they're hard stops. And be passionate about your work, because that's how you're going to motivate others. Right. So what are the opportunities? And this is the slide that I'm actually going to end with. And this actually leads into Blake's discussion and eventually to our breakout session. So when I think about leadership opportunities, these are the ones that I can think of, and I'm sure there are other ideas out there, but an APP lead or supervisor manager is what we commonly hear of. Also, along the same lines in leadership is assistant director and director. The APP program manager is the role that I have. And what I just found out is that, and I don't know if this is a good thing or a bad thing, because I was the first one in that role. They created that position for me because I did not want to manage people. I wanted to manage processes and quality improvement initiatives. That was what I really wanted to do. But since 2018, no one else has been in that role. So it's kind of good and bad, because I was hoping that that position would grow. And it makes me wonder if I'm not doing a good job. That's why there are not more positions for program managers. But then I just found out they are going to have 3 more program managers in our very department, in the cancer center. And it's covering areas like the fellowship program. They're going to have a program manager. Another area is an APP who is covering quality improvement and having monthly kind of M&M meetings. That's going to be a project for a program manager. And I forgot what the third one is, but it gives you some ideas of what might be available in your group. The other thing we're also looking at is an APP ran procedure clinic, or roles for APPs in procedures. That's aside from people who are assigned in the OR or in IR. This is going to be in our particular cancer center. Is there a leadership role for procedures? And how common is that? And what are people doing in their group? So I'm going to turn it over to Blake Foley, who will talk about the procedure component of just some ideas. And then after that, we'll break out into the sessions. So Blake, let me end this. Let's see, stop share. Okay.
Okay, there we go.
Okay.
Okay, guys, so just to kind of put a name to a face before I go ahead and put my screen up, my name is Blake. I'm one of the, I guess there's 5 of us total at our surgical oncology group at UT Southwestern. And I've had kind of an interesting opportunity over the past probably year and a half to start expanding upon procedures within our group and within the cancer center. And it's something that I've become really, interested in, because not only does it increase patient access, but you're starting to be able to see how you can, especially in a surgical role, prevent patients that are having to go through the emergency room, reduce costs, kind of continue to be that continuity of care for patients. So I'm going to talk with you guys briefly about that today before we kind of go into the breakout session. So let me share my screen. Alrighty. Can you guys all see this okay? Okay, excellent. So kind of just to piggyback off what Lan was saying. So for some of you, the idea of doing procedures may not sound appealing at all, and that's okay. But for some of us, I have found, being able to do things with your hands, it kind of breaks up those long, tedious days of clinics. And so we sometimes forget, even in the outpatient setting, the things that we can do as an advanced practice provider. I think we sometimes think that as an APP, that role only exists in an inpatient setting or in the operating room where you specifically need to go into an interventional radiology. But if you really kind of look at the things that you're doing from a clinic basis and within the scope of your practice, you can really expand upon things that you can do with your hands for patients that overall kind of increase access to care. So to start off, by no means am I an expert, but I do have some formal training. I have been a surgeon PA for 4+ years. It was my first job out of PA school. I have inpatient and outpatient experience. For those of you who are onboarding as the first PA into a group, I had that experience. It was like drinking out of a water hose. So I'm always happy to talk about that with people, things that I found that helped me throughout that experience. One of them being Lan, who is an important mentor for me during that time. My focus has mainly been gastroenterology, so gastric and AHPB, but I actually also had a 50% role that was melanoma sarcoma. As of January this year, I'm now 100% basically HPB focused. Things that I've been really interested in, as I've kind of talked about, is how an advanced practice provider can increase patient care, increase access to care, either that being things that you remove off of someone's template that you can see, open up new spaces for either your surgeon or supervising provider to see new patients. So one of the initiatives that I was able to lead last year was designing an advanced practice provider Metaport removal clinic here at our cancer center. And I actually saw somebody who was on from MD Anderson, and that is something that they have as well. So this wasn't our first idea. It was something that we did see at MD Anderson. And we kind of just sat around and we were like, why aren't we doing this? This is something that is within a scope of a advanced practice provider. And the procedure itself takes about 45 minutes. If you offload that to an advanced practice provider template, you can sometimes get in, 2 to 3 established patients onto your provider's templates or 1 new patient. So this was something that I had the opportunity to lead, and we successfully launched that after 6 months. And to kind of extend upon that, it was successful. And so now we're looking at ways that we can actually create an advanced practice provider-led procedure clinic at our cancer center. We are opening a new building in the fall, and it's something that we've actually started designating space so that we can actually have designated advanced practice provider clinics to perform routine procedures. So it's important to know that our role as advanced practice providers, it's changing over the time. People still are going into primary care, but 1 in 4 specialty practices are now having or are employing advanced practice providers. And I was reading this article from JAMA, and they were basically saying that 22% increase in specialty practice basically now have an advanced practice provider. And you're starting to see that there is this shift in people not especially going into primary care anymore. And in those specialty practices, those are surgical specialties, but then there are specialties such as oncology, cardiology, orthopedics, gastroenterology. In those specialty practices, they were actually more likely to employ nurse practitioners than PAs. But when you started looking at surgical practices, things that were more procedure heavy, you started to see a shift in that they were actually hiring PAs more. And it's not that one is more qualified than the other. When you actually look at it, it's more so it's a licensing issue. And so that's something that I was going to touch base with you guys on. The data from JAMA was back in 2018, but the most recent stuff is still kind of saying that about 1 in 4 advanced practice providers are still in a surgical specialty. So this is a long slide. Long story short, scope of practice, being able to know what you can do. As a PA, it kind of comes with our licensing, our certification, that we are already able to do procedures. We're supposed to be able to be trained to do them. That doesn't mean that you necessarily can do them. You always have to be privileged to be able to do so. But a lot of that's going to be governed kind of by your medical board, and it varies from state to state. And so one of the things, I don't know if we have, I'm trying to see everybody's kind of title. I know that we have nurse practitioners in our group as well, and we have a nurse practitioner as part of our practice. And one of the barriers that they have had, which is unfortunate, is that it has become a licensing factor for their ability to do certain procedures, whether you have a family nurse practitioner certification or an acute care license. Kind of for personal example for us, we have a nurse practitioner who's been on our surgical oncology service for the past 7 years in the inpatient setting. And due to some licensing issues, they basically were saying, you got to get your acute care license or you're not going to be able to practice in an inpatient setting. And so this is stuff she was highly qualified to do, but enable for her to still kind of practice how she was, she had to basically go back, get recertified. That's time away from what you're doing, time away from our patients, and an extra cost for her. So generally, kind of whenever you're starting off, it's good to know, what are the things that I can actually do, and looking up what your state laws are. Oh, there we go. Okay. So when we're talking about procedures that APPs can do, and I know that we're an AHPBA group, but I think we forget how many specialties there are routine procedures. If you actually look at these are just a few examples. Basically, any specialty that you have nowadays outside of primary care, there are things that you can do from a procedural role. I don't think that we realize how many of these things advanced practice providers are doing, and even nurse practitioners too, when they have the acute care license to do so. So there's always an opportunity to learn a procedure if that's what you want to do. I mean, even in neurology now, they're doing kind of Botox injections for migraines. So if you identify a need within your service, you're always going to be able to find something you can do if that's what you choose to do. When we look at our group by itself, when we're looking at kind of hepatobiliary and pancreatic disease, these are the common things that I do as well as my colleagues. And kind of the top 3 things are the most common things we encounter. And really what I want to highlight from this is that in the surgical oncology world, in some of these complex postoperative patients, the most common calls you're going to get are these 3 things after surgery. These are the most common calls, and being able to manage those, especially when your supervising physician or surgeon is in the operating room almost every day except 1 day per week, you're able to basically be that point of reference, that point of contact for a patient. Just because a drain is dislodged or a feeding tube is clogged doesn't mean that a patient has to go to the emergency room. These are things that you can be trained to do, that you can learn to resuture a drain, you can learn to declog a feeding tube, replace a feeding tube. It's things that don't always require a patient to have to go to the emergency room. And what our patients generally like is that they know you. So if they have an issue, they're not now having to go to the emergency room and meet somebody who knows nothing about them. They're able to see you in clinic. You can fix the problem in real time. Sometimes you're not able to, and that's when you send them across the street to the emergency room. But for the most part, with the proper training, you can handle the majority of kind of routine postoperative calls that you get. And so these are things that we have worked with as a group to be privileged and to start to gain privileges. And some of us are able to do all of them. Some of us aren't able to do all of them. And that's kind of also the beauty of it too, is that you can kind of decide what you feel comfortable doing. So to expand on that is standpoint, when you're looking at what your privileges currently are, sometimes people don't even know what your privileges are. So being able to identify what things can I currently do in my role, and then looking at your practice and seeing what are the most common things that we encounter, either that we have to send a patient to interventional radiology, or we send them to the emergency room, and how can we maybe take that part and I can take care of it. So usually if you can show, and this, if doing procedures is something that you are interested in, if you can identify a need that increases patient access, decreases emergency visits or hospital admissions, and reduces costs for a patient, you're generally going to get the support of your staff behind you. The next step becomes credentialing resources and privilege to learn. So what does a training curriculum look like? And that's going to look very different across institutions. We're at an academic institution, and so we do sometimes have easier access to certain things that somebody may not have in a private practice situation. If people are really interested in going the full kind of surgical procedural route, there's residency programs available. There's some Emory, USCF, Johns Hopkins. They have surgical residency programs for physician assistants and nurse practitioners where you basically get, I think they're about a year that you get basically certified to do any procedure basically you want to do. For some of us who are already kind of in our role, you may not want to take the time to go back to school to do those things. And so then it becomes a question of, is there somebody that can proctor you? So for me, when I kind of identified those things that I wanted to expand my privileges in, half of it's just asking someone who is willing to teach you. And that role in terms of them proctoring you can be simulation labs. Not every campus has access to this, but if you do, it's a great resource. You can even, if you have a physician assistance program near you, or you have a medical school near you, they're very supportive and somebody always wanting to come in to learn new procedures. Oftentimes, if you're in the surgical world, your surgeon may be doing stuff in the outpatient setting or in the operating room. Join them. That's the best way, especially in the operating room, to start to learn skills in terms of suturing, where you're not having to worry with the patient awake just looking at you. You're a little bit less stressful. Then it comes down to what are standard operating procedures. These are things that for any type of privilege you learn, any type of procedure you do, going through and understanding what that looks like is a step-by-step process of you inject with this certain type of anesthetic, you suture with this type of thread, making sure you are aware of everything that is in there, because when you're privileged in that, it's your opportunity to also change those standard operating procedures to make sure that you are covered in the event that anything ever goes wrong. And then it's getting those privileges approved. So at our institution, generally there's a proctoring situation where you will have to, shadow your provider in clinic. And what we have deemed generally appropriate is, for any type of procedure you're doing, is being able to do 10 of those by yourself without any complications, without needing assistance. Now, with that said, at the end of the day, you have to be comfortable with what you're doing. So if at n equals 10, you're still not comfortable, that's okay. And so I would always encourage someone to speak up. Sometimes providers get very eager to just get you going and start helping out, but at the end of the day, it has to be something you're comfortable with. So when I first started kind of expanding my procedures, there was a lot of the times where the physician was right there with me, and then gradually they would step away, and then I was doing them by myself. And one of the things that has really helped me was creating a template that's parallel. So anytime I'm doing a procedure, it is at the same time in clinic that a surgeon is available. They don't have to be in the room, but it is in the event that I need help, something I'm not sure about, I have somebody on call. And I understand that that may not always be feasible for people, but I think the biggest part is generally advocating for what makes you feel, the safest at what you're doing. And generally they're pretty supportive because you're helping them out at the end of the day. So they'll probably be flexible trying to help you too. And then just continuing education. So for anybody who has done suturing but wants to be able to learn more, if you look up advanced practice provider skills workshops, there are conferences that happen throughout the year. You can use your CME money too if you have it, where it's usually 2 to 3 day conferences that teach you how to use ultrasounds, teach you how to suture, teach you how to, do lumbar punctures if that's something that you want to do. So kind of where we're going to break out is I know what we're doing at our institution, but trying to kind of get a gauge for what other people are doing, if any procedures at your group, and what your training has looked like, how you manage that time, because it is an extra responsibility. And sometimes when you're doing a procedure, you may be held up for an hour. So how do you manage those urgent calls that come through? Recognition that you are providing now a service. So is that something that your institution pays you more for? And then also barriers that you might be encountering during the time. So I would love to hear everybody's thoughts on that.
Thank you, Blake. So before we break out into the